Good morning. This is Emily Henderson, pharmacist with the Kentucky Hospital Association. Thank you so much for joining this month's Kentucky SOS webinar. If you are not currently on mute, please mute yourself. We will begin the webinar in just a moment. A few housekeeping items though. If you have questions during the presentation, by all means, please type them in the chat box and Dr. Johnson will address them as she's able, either during her presentation or at the conclusion of the presentation. Also at the very end, you will be able to unmute yourself and ask directly if you choose to do that way. So we will get started in just another minute or two. Several are logging on. Again, this is the Kentucky SOS monthly webinar entitled More Than Opioid Stewardship. Okay, it is 2 after the hour and we will go ahead and get started. Again, this is Emily Henderson, pharmacist with the Kentucky Hospital Association. Excited that you have joined this morning for the Kentucky SOS monthly webinar. The webinar this month is entitled More Than Opioid Stewardship, and Dr. Jessica Johnson, pharmacist with Robley Rex Medical Center in Louisville, Kentucky, will be presenting. Dr. Jessica Johnson currently serves as a clinical pharmacist practitioner with Robley Rex Medical Center. The bulk of her practice time is spent providing outpatient medication management services to all patients at all stages of use and recovery from drugs and alcohol. Dr. Johnson draws on the training that she received as an ambulatory care pharmacy provider at U of L Health and as a SAMHSA-funded academic detailer with the Kentucky Pharmacists Association. During her initial 18 months at Robley Rex, she has increased the percentage of patients with alcohol use disorder who receive medication management, managed the implementation and ongoing services of a sublocate clinic, and created harm reduction services and counseling for veterans who use drugs. She is an advocate for autonomy and patient-centered care of patients with substance use disorders. Dr. Johnson provides education for pharmacist learners in both didactic courses and also as an experiential preceptor for final year pharmacy APPE students and PGY1 pharmacy residents. I am honored that Dr. Johnson is sharing her time to educate Kentucky SOS. On a side note, she presented this for the Kentucky Society of Health System Pharmacists, KSHP, in the spring, and I knew immediately that Kentucky SOS needed to hear this. So Dr. Johnson, Jessica, please. We're looking forward to hearing from you. Kentucky SOS welcomes Jessica Johnson.
Thank you, Emily. That is very kind. And yes, Emily emailed me, I think even maybe the next day, to ask me to come speak with y'all sometime this summer. So I am thankful for the opportunity. And we're just going to go ahead and jump right in. She gave me a very kind introduction. So that gives you a little hint of who I am and what I do. Anytime that we present as VA personnel, we are asked to remind you that these are not the views of the United States government or the Department of Veterans Affairs. Those are my practice sites, but they have neither reviewed nor approved this presentation. But I have no disclosures or conflicts of interest to report in talking with you today. And today we're going to focus on two things. We need, as health systems in Kentucky, to assess our existing practice gaps. We've put a lot of time and money and education into the treatment of people who use drugs, particularly since early 2000s in response to overdose mortality. But we need to know where those practice gaps are because we are continuing to see those numbers rise. And we are going to assess where those gaps are and then talk about how we provide evidence-based services to improve those mortality rates for our people who use drugs. I do have the chat open, so I will try to monitor that as best I can. I like to address questions as they come, so please feel free to do that today. So the things we're going to be taking a look at are current patterns of drug use and contributors to the overdose crisis, those evidence-based interventions, both for people who will continue to use drugs and those who are ready to slow or stop their use, the evidence for the medication treatment of opioid use disorders, and then give you all an opportunity to think specifically about where do we have like immediate impact, kind of low-hanging fruit, low investment opportunities to make a high yield when we're talking about positive outcomes for our patients. That is a lot to promise, so I hope that I'm able to deliver. Three things that I ask people to keep in mind whenever I present and whenever we're talking through scenarios. I think it is important. We hear a lot of fatalistic news reporting and a lot of like big urgent reports about the opioid crisis. And I don't think we often sit down to talk about what is that and what does it look like when we solve it. We say that we want to solve it a lot, but we don't specifically talk about what that means. So today, while I'm working and speaking, I'd like you to think about what does that mean to you? Does that mean fewer patients using drugs? Does it mean that our mortality rates decrease? Does it mean that our patients are able to engage in socially productive roles and have their family back? Do we see crime lower? So what kind of outcomes are you looking for? And I think it's important to celebrate our current successes and then be able to assess where we have some opportunities for improvement. And again, we want to focus today on low risk, high reward. So what's easy to implement and where can we make big, significant impacts right off the bat? So we're going to have a patient that we follow today. So this is Mr. Trooper, and his ER chart indicates that he's a 47-year-old male presenting for the fourth time in the last 3 months with a complaint of just like too much pain. My whole body hurts all the time. The ED note indicates that his last UDS was positive for cocaine and benzodiazepines, and he's asking for oxycodone for his pain today. He moved to the area about 4 months ago and stays with friends, but has no permanent address. Most recently in jail for a 3-week period. Vitals are normal. Last time he was here, we discharged him with 800 milligrams of ibuprofen, TID, PRN, and a 14-day course of Bactrim, BID. When we're thinking about opioid crisis, we need to talk about how we've responded thus far. And this is going to affect our patient. So to this date, we have responded with opioid stewardship programs. We have responded with prescription drug monitoring programs. We have responded with education, with naloxone, syringe programs, a lot of money. So this patient that we have in the ED may be somebody who our clinical pharmacist team is assessing with respect to opioid stewardship and saying, you know, this patient seems kind of high risk based on these factors in an algorithm or a NARCS care score or something. And so we're going to use non-opioid medications to treat his pain. We're probably employing a PDMP report like Casper to make sure that we know what kind of opioids he's had in the past and recently. Hopefully our ED is giving him some naloxone. We may be working with someone who has connection to syringe service. But these are the focuses that we've kind of had. And so when we talk about that, that's like a lot of work. And you would think that we're doing very, very well. So we've seen one decrease, and we were very happy about that and had a lot of reasons to be very proud of that. That decrease happened from 17 to 18. And so that really may very well be due to all of that work that we've been doing and the ways that we're changing how we care for these patients. However, we recovered almost the entirety of that decrease in 2019, and we finally do have provisional data out to actually January of 21, but through December of 20, for the 12 months preceding, we actually increased to 93,000 overdose deaths in the country. And the data that you'll see on this next slide has been updated since I submitted these slides to KHA. So this had provisional data through June of 2020. When we extend that out the year to December, Kentucky was #1 in the nation for increases in opioid mortality. #1 with an increase of 53.7%. So we over doubled our overdose mortality in the midst of this other significant public health crisis. So Kentucky is in sort of a crisis point where we need to adapt the interventions that we're using currently and expand them and think a little bit differently about what care for this patient population might mean. So what do our current interventions fail to recognize? And I think two of the most important things that I tell my patients on our first visit is that drug and alcohol use is really rational. I have a patient who told me one time that my brain is too hard of a place to be. And if that is the case, and I work with veterans, so my patient population is a little bit higher. They've had a lot of adverse experiences. But if your brain is too hard of a place to be, you will do nearly anything to avoid it. And so I share with my patients that, whatever you've done to this point has been protective. It makes a lot of sense. And one of the things that we need to help you with is recognizing when those protective measures are no longer healthy and how they're affecting your overall physical health, how they're affecting your mental health, how they're affecting your ability to function in this society, and help you learn new ways to do that. So we don't always really think about and work with our patients in a patient-centered way about why they use drugs. If we're going to help them to eliminate that coping mechanism, we really need to make sure that we're providing something else in that space. We cannot make drugs easier to get than the intervention itself. A lot of our patients have very different goals of treatment. Treatment does not have to be a dichotomy, right? So we don't have to have this idea of a patient uses or a patient doesn't use, and there's no space in between. There's a universe in between and a continuum where a lot of people are more comfortable, especially at the outset. So if with my alcohol use patients, I have a lot who will get referred to me, and the first thing they say is, I'm not taking antabuse, because they think that's the only answer. And if I talk with them and kind of figure out that, they're late 30s, they've been drinking since college at the same rate, like a lot of our college students do. They don't want to drink a case of beer anymore on weekends, but they'd like to drink some. There's an intervention in that continuum that can help them meet that goal. They may not be somebody who can drink long-term. They may not be able to have that moderate level of use, but let's get them in the door. Let's get them talking with someone about what seems achievable at that time. And then we can adjust that goal if we need to as we move along. So recognizing that our patients may need different options for treatment aside from what we've typically shared. We have a lot of changing use patterns, especially in the state of Kentucky. I share with my patients that if they are using non-prescribed drugs, they need to assume that there is fentanyl in them. I would consider marijuana the one exception to that. There are a number of chemical reasons and physical flashpoints and boiling point kind of things that make fentanyl contamination for marijuana not particularly useful for smoking, vaping, or baking. Other than that, if your patient is using drugs, they need a Narcan kit. Because they almost all have fentanyl in them. My patients share with me that it's very, very hard to get hold of pure heroin anymore. And so we need to recognize what that risk is and help them to assess that risk and mitigate it if they're going to continue to use. And then I think the last thing that we fail to recognize is that mortality isn't our only metric. And that's something that we've really had to confront with COVID too. I think a lot of times when we're dealing with public health initiatives and things, it's easy to say, well, it's 99.5% fine. It's not, only 0.5% of the people are going to die. There are a lot of long-term outcomes. We imprison more people than anywhere else in the entire world based on drugs. We have children who are growing up without their families of origin and without their families of birth. We have failure to re-engage in employment opportunities and things like that. So a lot of those things that cause drug use are also then kind of reinforcing that cycle. And so if we're able to alleviate some of those outcomes, then that's also a success. And again, the biggest thing is we cannot make getting care harder than getting drugs. Especially for someone who is in the drug market, it is very, very, very easy to get drugs. And everything in their body is telling them that that's what's going to keep them safe. because that's what's going to prevent withdrawal. And so if we are putting up artificial barriers or creating policies that may at one time have been what we thought was the best option, but have changed based on the enormous amount of money that we're funneling into this, then we need to make sure that we're also updating our policies and practices so that our interventions aren't so kept behind high gates that they're ineffective. I think it is important to note, so this is from the CDC State Intentional Drug Overdose Reporting System. This is for January through June of 19, which was the last update. I think one of the things that's hard is we don't have a great way to capture this data. So it's collated through death certificates, and that's fairly imprecise. So we might have a patient who has numerous things positive on a tox screen or on a UDS that may have contributed, but only one of them gets coded. And so that one counts as like a fentanyl death, but really it may have been polysubstance use. We sometimes don't have any information about a substance that would have contributed. So these are kind of what I like to call best guesses, but it does sort of show us trends. So right now, our biggest fatality problem is definitely illicitly manufactured fentanyls. Those are being brought in largely from Mexico and China, very, very cheap, very easy to add to something. So, you know, people who sell drugs are business people. And I think a lot of times we think that they're not watching out for their patients. They really are, because a dead user is not going to be beneficial for them financially, if anything else. But they are putting fentanyl in things like heroin because it's so much cheaper. And so, you know, that's just straight stone cold capitalism. And so that really is causing a lot of the risk right now because patients don't know what's in their drug supply. So if I go to a bar and I ask for a gin gimlet, I know exactly, I have available to me the information about how strong that is. I know that it's not going to have something else weird in it. And I'm able to make an informed choice about how I use that drug. Our patients who are using non-prescribed drugs don't have that choice. And so we need to help give them information about that as we understand it so that they can make different decisions, whether that's to use less, whether that's to try a different supply, whether that's to start slow, make sure somebody's around, that kind of thing. And so again, this is not me saying that smarter drug use is good. I'm just saying if our goal is to keep our patients healthy and help them make steps toward a healthier lifestyle and healthier decision-making, that's an important step to talk about because it's not taking us from here and here, it's recognizing this vast space in between. The last thing I would note on this slide is that this will change very quickly. This is going to look very different in 12 months. The drug market and drug use is just a fact of life, and we have patients who are going to use drugs. And so that will be the case whether we outlaw fentanyl, that will be the case whether we further reduce our prescription opioid writing, or whether we start to make changes about how we prescribe stimulants to patients. There will always be a demand for drugs. And so rather than focusing entirely on supply side interventions, we also need to incorporate these demand side interventions that allow us to understand why people use drugs and help alleviate that need and that decision rather than just focusing on what they can actually access. Along the lines of that is a really cool study, I think, from Mark LaRochelle, who's at the Great Center for Addiction up at Boston Medical Center. Boston Medical Center and Brigham both have very, very progressive and active addiction consult teams and very large SUD programs. So they do a lot of really good research about how we better target interventions and a lot better, they help us to really understand the ways in which we can better serve the patients that we're purporting to serve. And so this Touchpoints study came out in 2019, and I think it's really informative when we start to talk about where to make those quick interventions. And what the team did is they looked at about 40 different touch points, so opportunities that we can make an intervention, and found that there are some that really signal that a patient is an exceptionally high risk for an opioid overdose that is fatal. And so 4 of those ended up being sort of that bread and butter that we like to think about when we are health systems. I am a pharmacist by training, and we love this stuff, right? Like we love rules and setting up policies, and setting up algorithms to try to better understand how to do this. And that's all in that top section of opioid prescription touch points. So what they found is that there are 4 that do seem to have some pretty significant impact on whether or not a patient is going to be high risk for a fatal overdose. And those 4 were high dosage, benzodiazepine co-prescriptions, and then multiple prescribers or multiple pharmacies. And these are all things that we really actively work on in our health systems. And so those are, like, collectively as a combined outcome, they increase a patient's risk about 13 times. So their standardized mortality ratio is 13 compared to a patient who doesn't have these touch points. But then they identified that there are 4 others that don't revolve around prescribing and revolve more around encounters. And these had a much more significant impact on someone's relative risk of a fatal overdose. And so I think these are places that we don't as quickly think about as health systems for making an intervention, because they're harder to fix. And they're harder sometimes to think about our responsibility to fix, right? But these are really where we're going to see a lot of improvements very quickly. So the 4 that really, really elevate that risk are someone who leaves what they called an opioid detoxification. So if they've been in an inpatient residential facility where they were practicing abstinence and didn't have access to an opioid, and they leave without a maintenance medication, so withdrawal management only, they are significantly higher risk, which makes sense, right? Opioids develop tolerance. Someone's tolerance can fade over time if they don't have access to that drug. And so that intuitively and scientifically makes sense. Similarly, I'm going to jump down to the last one, release from incarceration. I think we have some people on here from SANE, and I am generally on social media fairly critical of some of our criminal justice programs and their reluctance to really integrate evidence-based medicine. But I have to say that NKY is doing a great job. So they have a program that's a court and jail diversion program where the patients have access to all 3 medications for opioid use disorder. So that team is really intentionally thinking about how to integrate that group back out into the community rather than bringing them into jail, forcing them to go through opioid overdose or withdrawal, making them miserable while they're there because they have continued cravings, they have withdrawal symptoms, and then sending them out into the community with a lower tolerance and an absolutely devastating rate of overdose. So props to NKY, that's my home as well. And so it gives me great pride to be able to say that I'm proud of something happening up there. It's a great model that I hope we see replicated around the rest of the state. These other 2 critical encounter touch points are non-fatal opioid overdose. So patients who have overdosed before are more likely to do so again, and that tends to be a higher mortality event. And then anybody who gets admitted to the hospital for an injection-related infection. So skin and soft tissue infections. We're looking here at new HIV diagnoses, hepatitis diagnoses, endocarditis. Those patients also at an elevated risk, generally also due to changes in their tolerance. So all of this information that we have rumbling around in our heads should kind of lead us to start thinking about 4 things for your team. Where do we want to focus? So which of these exceptionally high risk patient populations do we have an ability to affect quickly? And let's put some resources there and manage that and put in interventions for that, and then think about the next step. What are existing barriers to care for those patients? Do we need a new referral pathway? Do we need a different set of prescribers? Do we need some education for our teams about which interventions we decide to deploy? What are the existing barriers to care for providers? So do your providers not feel like they have the resources that they need? Time tends to be a very huge one that people bring up. And then what existing processes can we modify for increased impact? So do you have a standardized overdose reporting system? And if so, does that automatically trigger a naloxone counseling and a naloxone kit to be dispensed? Does it automatically trigger an alert and a referral to an ex-favored provider? Do you have existing order sets within your emergency department to initiate withdrawal protocols? And can you initiate opioid agonist therapies on top of those? So let's use the existing processes that we have. We don't have to start over, but to really deploy those effectively and intentionally to make a better impact. So if we're thinking about Mr. Trooper, what touch points are present for him? We again have uncovered that he had oxycodone and or is asking for oxycodone on this visit. Positive for cocaine and benzos previously. You have a MedRec tech, which is a great idea. And he uncovers that you have 2 recent 3-day prescriptions for opioids from other area hospitals. This guy moved to the area 4 months ago, no permanent address. Reminder that we gave him ibuprofen, TID, and a 14-day course of Bactrim last time he was here. So in the chat, just real quickly, if you can think of any off the top of your head, which of these touch points that we just identified are present for Mr. Trooper? And I'm going to flip back to that slide so you can see them. So of these 8 things, are there things that we kind of should have flagging in our heads for him to be especially high risk? Nobody. So things that I'm seeing for him are that I am worried about his recent release from incarceration. I tend to associate Bactrim with skin and soft tissue infections. So I would want to know the indication for that prescription that we gave last time. He's getting some multiple prescribers and likely multiple pharmacies because of these OR or ED visits across the city. So those are things we kind of want to keep in our mind about. No judgment against the patient himself, but these are things that make him higher risk. So I try very hard to remove any kind of subjective language. We have some studies that indicate that stigma can persist through notes and change the care management plan for patients even 4 to 5 providers later. And so a very easy thing to do is to be able to say, instead of frequent flyer, asking for oxycodone, say, 3rd visit in 4 months, sickle cell pain crisis, has found that oxycodone works best for his pain. And then down the line, way after he's been in your ED, those outcomes are going to change for that patient. I would also highlight that he was on, he had a benzo on his UDS, and so he doesn't really see any prescriptions for that. So that might be something that he's using in a non-prescribed fashion. So that's a lot of information. What do we do? So we have to think about ongoing health and where we provide support. This talks a little bit about language. We have 2 resources here, but in general, just think about removing things that are subjective and making them objective clinical reports, and that drastically changes outcomes. When we're talking about like 101 level things for people who use drugs, immunizations make a huge impact, right? So usually how I present this with my patients is to say, I know you're not ready to quit using drugs. There's some things that I think we can do to keep you a little bit safer so that we aren't using drugs and getting HIV on top of that. Let's talk about moves. So immunizations are huge for that. Many of our patients will qualify for hepatitis A and B. So running a titer on that quickly and helping them get connected to that care is good. Obviously, if we have someone who's injecting drugs, we want to make sure that their Tdap is current. Based on smoking status, age, concomitant disorders, we're probably indicated for a Pneumovax and or Prevnar if they're above 65. If they are a living human being, they are indicated for annual influenza and now COVID. So those are really easy interventions that we can make in primary care, right? If we have an idea that a patient's using drugs, this can be part of our preventive health, and anything that we can do to automate that for our primary care providers who are so overstretched and exhausted all the time is good. So order sets, clinical reminders, anything that would be good for them. When we kind of jump up to the 201 level and something that might be a little bit more advanced, harm reduction counseling has demonstrated outcomes on all aspects of use. So safer use, less use, engagement and care. Again, these are patients who don't always feel super comfortable coming to a healthcare setting. So if we can offer them this as an intervention, that's a good starting point, and that's a good initial door. Naloxone and overdose prevention education is an automatic. Like that has to happen. If you have a patient who's using drugs, there is no contraindication to naloxone, very few documented allergies. Generally, if we're looking at what we would consider an allergy, it's actually just an expected outcome of putting someone in automated withdrawal from opioids. So naloxone all over the place, just blanket it. Safer drug use tips. So this is never going to be a safe thing. This is not something we encourage to our patients, but if they are going to continue using, these are things I ask my patients to keep in mind. I do not want them to use alone. Nobody is there to respond if you're using alone. You should not think, oh, I'm using with my friend, and then both of you use at the same time. Because if you both nod out, then nobody's there to save you for that either. This little yellow app on the side is called the Canary app. I have all of my patients download this to their smartphones if they have one. They can, if they're in a position where they feel like they do need to use alone, they can go ahead and activate that, and it puts somewhere on their body. And if they don't make micro movements for at least 60 seconds, it sounds off this huge alarm to try to wake them up just in case they've like passed out. But then if they're in overdose and don't wake up in response to the alarm, it activates the emergency system or their closest contact. There's also a 1-800 hotline that is in the notes of this section. So, you know, if you have a really good admin resident or intern or something, you know, having them come up with some sort of handout for your teams to hand to patients who use drugs that share these pieces of information, including that hotline number or apps, is really, really engaging for a patient and reminds them that we care about their overall health, even if they continue to use drugs. I do ask my patients to drug test for contamination. Functional test strips are becoming more widely available. And so that's where they can just take a little bit of their supply, dilute it, put in the test strip, just like you did in like AP chemistry, right? And if it's positive, then my patients may choose to use less. They may choose to discard that batch and try a different one. They might just double check and make sure they have naloxone, but that gives them more information about whether or not what they're doing is contaminated. I ask my patients to use the same supplier whenever possible, because people do watch out for each other, and you kind of get a vibe for what kind of quality different people have. Dealers will often share whether or not it seems like there's a bad batch floating around. So just as a safety measure, we ask that patients don't share works, right? So clean syringes, we want to make sure that they're not sharing straws, that they're not sharing any heating elements or anything that would touch their body, because we don't want those infectious disease transmissions. And then again, that app that's there for Canary. Any kind of whole health counseling you can do, right? So sometimes my motivational interviewing for a patient, especially with something like drugs or amphetamines, is how's your hypertension going? Like your pulse and your heart or your blood pressure are very, very high, or your A1C is really high. What if we reduce this a little bit just to make you healthier? And then it's not quite so hard as thinking, oh my God, I have to stop this entirely. I'm going to be in withdrawal. I don't even know what to do. There's no support. And then one other thing I like to really highlight is syringe access. So Kentucky is actually #1 for this too, and this is better than us being #1 in the increase of overdoses. We have more syringe service programs than any other state in the nation. And these are demonstrated public health positive interventions. So these actually are demonstrated not to increase the number of people who initiate drug use or the frequency with which someone uses, but they actually do reduce crime rather than increase. And patients who participate with an SSP are more likely to engage in treatment, perhaps as often as much as 5 times as likely. That study's in the notes for this slide. So we do see like a reduced injection frequency. We see increased untreated drug rehabilitation programs. So these are like exceptionally positive interventions. We are seeing kind of like an attack on syringe service programs right now. Scott County, Indiana has voted to close theirs. So any opportunities we have to advocate for this public health intervention and make sure our patients know where they are is very important. They also offer wraparound services much of the time. So they would have things like fentanyl test strips or works. They often offer things like family counseling, referrals to care for hepatitis, any kind of screening that you could ever imagine. So they're really, really good networks where people can feel safe and accepted and not judged. The one, at least in Louisville, is anonymous. So they get just a short ID number that allows us to continue to report for grant funding, but generally very well received, very well evidence-based. And the one problem that we sometimes tend to see is litter. So we should pay attention to that. That makes communities not want to have them, but in general, a very, very positive public health intervention. The next step that I would really think about when I'm continuing to think about patients who are going to keep using drugs is PrEP. So when you're thinking about your health system, evaluate who prescribes PrEP, who has the ability and the authority to prescribe PrEP, Is it available in places where patients can access it easily, like primary care, or do they have to have a specialty referral? Injection drug use is our second highest risk factor for HIV in Kentucky, and we are seeing an increase in this. It's kind of working down the I-64 corridor from West Virginia. So PrEP is kind of a big thing that we need to be implementing right now. Your pharmacists can help manage this via board authorized protocols and would love to do so. This is something that I offer in my clinic at the VA out of our substance use disorders program. For PrEP, we use emtricitabine with tenofovir, either the TDF or the TAF formulation. TAF is off-label, so the Discovery is off-label for infectious or for IV drug users, but we see like an 80% reduction in HIV transmission from needle sharing and from infectious or intravenous drug use. PrEP on demand is something that we offer sometimes to people who have higher risk because of the number of partners they have for sex or not knowing what their partner's status is. PrEP on demand doesn't really work for IV drug use. So this is one that we would want patients to take every day. I'm watching the cabotegravir data pretty closely to see if that's going to be an intervention that's available to our patients. We want to make sure these patients get quarterly HIV testing, because if they do seroconvert, we want to be sure to start them on a full appropriate HIV treatment regimen instead of just a prevention regimen. We also really have to watch that Hep B, because a lot of the medications that we use to treat Hep B are also the ones that we use for PrEP. And we want to make sure that we aren't reactivating anything if someone discontinues. This is sort of a workflow for how you can think about PrEP, how you can implement that in your clinics. Where do you already have a clinic that's doing something like this? So do you have pharmacists who are deployed for things like medication management for anti-coag that you can't really use as much anymore because your system's not using warfarin as much? Let's convert those. Let's make those PrEP clinics. Let's get them in with IDs so that we have a good integration of care. This is an ideal option for telehealth because this is not something that has to be in person every time. And so we may be able to kind of offer a lot of this in a way that reaches more patients because we don't have that barrier of them coming to an office, which can be very, very difficult to get a patient to do if they feel that they're not going to be accepted. And then we have to think about wraparound services, right? So patients use drugs for a reason. And so we have to address some of those reasons too. And our health systems, unfortunately, bear a lot of that burden. So do you have a care navigation program for your oncology unit? Should you get one for your patients who use drugs? Do you have housing resources? Do you have connections to ways to help them stay food stable, integrate with the workforce, peer support groups, other groups, family planning, dental and primary care? Again, patients who are being treated for substance use disorders, particularly on opioid agonist treatments, have much higher retention and care for their other health concerns. And so it's a really, really high priority that we make sure that patients who use drugs know that we care about them and their health and that we are a safe place to seek that help. These are more key questions for your teams, right? What kind of training do you need? Where are you already doing this? You just have to flip the actual service itself. Who are the champions? Who loves this? I love this. I'm talking a mile a minute. You have people like me at your site. So figure out who is really invested in this and who really wants to do this better. Put those people in charge, put those people on teams because they have good ideas. We have to find them. What's high impact, low barrier? All right, so you have like an awesome mental health PGY2 pharmacy resident. She's in there talking to Mr. Trooper, and he says that he uses cocaine pretty regularly by snorting, and he buys it from a neighbor that he's known for years. Last year, while living in Arizona, he did start using heroin. His mom died, and so that was sort of a trigger for him. He started smoking it and then moved quickly to injection. He has maintained his heroin use here in Kentucky. He doesn't really like to inject meds and would like to be able to quit using heroin because it feels unsafe to inject. Feels like maybe that means there's actually a problem if he's gotten to that point. He does not want to stop cocaine. That's a non-starter. We're not talking about it. He is quite clear that he has not used benzos and doesn't like how they make him feel. So he's feeling antsy in emergency rooms because he thinks people treat him like crap here. So what are two interventions that your resident might decide to offer Mr. Trooper while he's right here, right? So even if he bolts out the door because he's uncomfortable, what are two things that we could do pretty quickly? I know some of y'all practice. You can unmute and say it out loud if that's better. Naloxone, yes. I have in the notes that there's not a wrong answer here, but your number one right answer is always going to be naloxone for this patient. Thank you, Elizabeth. I think it's important for him to know that there's probably fentanyl in his cocaine, right? So that's just something we could share quickly with him. Does he want to talk to somebody about PrEP? Does he want to talk to somebody about medications for OUD? Does he know where the syringe program is? Just quick things that we could offer, because again, a lot of times these patients leave unexpectedly and we want to make sure that we're making an impact where we can. So let's move on to the last section. And this is something I usually, when I teach for students, do in 4 hours. So we're going to do a very quick run through of medications for opioid use disorder. Our guidelines for this are the American Society of Addiction Medicine, and they did a focused update in April of 2020 that really significantly revised their guidelines on how we treat this. I think initially when we had buprenorphine available to us, our thoughts were that it should be a very short-term medication, that we needed to taper pretty quickly and wean patients back toward nothing. We are learning a lot more. And the simple fact of the matter is, if we have a patient with an opioid use disorder and we can start an opioid agonist treatment, so either buprenorphine or methadone, that reduces their mortality risk by 50%, 50. That's an insane benefit. That's an insane impact on someone's life. And our number needed to treat for buprenorphine is 3. So when we think about that in comparison to something like a statin or even TPA or something for stroke, like this is a significantly lower risk intervention. So the guidelines were revised accordingly. The main points of ASAM's guidelines for 2020 and what the biggest changes were the following. All 3 options for medication maintenance treatment should be available to all patients with a diagnosed use disorder or opioid use disorder. We will talk in a minute about which ones we might want to give higher preference. ASAM's indication is that all 3 of them should be available to every patient. They should be able to make the choice for themselves. So we don't really kind of shun people toward Vivitrol for any certain reason. We want to make sure they're safe for all 3, but if there's a safety issue, or if there's not a safety issue, the goal is to let them choose. Low barrier access is priority. So while staying within regulations, and KBMLs are, I would say, this is Jessica, not Jessica the VA, overly restrictive. While staying within regulations, telehealth is important. Low barrier access is important. Minimal UDS screening is important. This is a life-saving medication. We need to not make it a very difficult thing to access. ASAM now recommends that we don't automatically withhold because of concomitant medications like benzos or use of non-opioid substances. For most patients, the benefit will outweigh that slightly higher risk of a CNS depression and respiratory overdose. There is no longer any recommended timeline for pharmacologic treatment, and this feels wrong and weird to a lot of people. But the simple fact of the matter is these patients stay alive if they're on this medicine. And so for many patients, this will be lifelong. I am a pharmacist who's a big fan of deprescribing. I did a lot of work in geriatrics, and so I don't like patients to be on meds that aren't helping. And I think always our goal with most patients is going to be to have them not reliant on medication therapy, because nothing is benign. However, just like I would not expect most of my patients with diabetes to successfully be able to manage that with diet and exercise once they're to the point of needing insulin, I do not expect most of my patients with an opioid use disorder to be successful and safe without a medication that is managing their cravings and managing their, preventing them from returning to use. For number 5, psychosocial treatment is often recommended. I would go ahead and say it's 2021 in a pandemic world. It's recommended for all of us. But a patient's ability or unwillingness to engage in that should not preclude their treatment. So this is basically saying your patients need this. We hope they will also do these other things. They are remarkably beneficial, especially when we're talking about stability instead of just safety, but we cannot use that as a gatekeeping measure anymore. We'll talk very quickly about all 3 meds. So methadone is a full opioid agonist. So this is an opioid. It does have the longest history of data, especially pertaining to things like reduced involvement with criminal justice, reduced return to uses, length of time engaged on therapy. Like, we have 50 years of data on methadone's efficacy for this. It is the most highly regulated. So of course, this needs outpatient treatment programs. It has to be a licensed OTP. They have to go there to dose. We do have some restriction lifting this year with the public health crisis, and things have gone very well. And so I think the hope would be that some of those restrictions are lessened going forward so that more people can have access to this as a consideration. Important things to keep in mind: this does prolong the QTC. So if we have a patient who's on some of our atypical antipsychotics, or even some of our SSRIs, fluoroquinolones, certain other antibiotics, we want to keep in mind that EKG factor. It does have a very long and variable half-life. So that's variable within people. Mine at initiation would be higher than mine after 4 months of use. Mine would also be different than Emily's. So that makes that first 2 weeks extremely high risk for overdose, just because the PK and the dynamics of it are so complicated. It generally will not appear on a PDMP. So your inpatient providers need to know this. You need to know how to order methadone for your lab results. You need to know if it's a stat, because you may have some patients who are unable to provide you that information. And if they're maintained on methadone in the community, they need to be maintained on methadone in your hospital. They should not be going through withdrawal in your hospital if it is not an absolute medical necessity for them to not be on methadone, which is what it says below. Buprenorphine is our next one. This is a partial opioid agonist, which means that it does not have the full agonist response, which makes it very, very helpful for this, because the risk of respiratory depression is very small. It is not very small for children. And so storage of this is very important. But in general, for someone who is opioid tolerant, which is who this would be used in, opioid agonists activate 2 different pathways from the mu receptor. They activate GPCR and they activate beta arrestin. And the way I teach it to my students is GPCR is the good side. That gives us analgesia. Beta arrestin is everything else. So it's euphoria, which some people consider to be the good side. It's constipation, it's adrenal suppression, it is respiratory depression, it's tolerance and withdrawal. Full opioid agonists activate those pathways exactly the same. There's no preference. Buprenorphine activates analgesia and GPCR preferentially. So we get way fewer side effects, not none, but way fewer, way less risk of respiratory depression. And we're still managing a craving. We're still managing a return to use. And it's actually a really good analgesic if we are dosing it appropriately. And so this is a great medication for patients that have concomitant pain and opioid use disorder, which is a lot of our patients. That agonist activity does lead to that ceiling effect. That's why we worry so much less about respiratory depression. It has very high affinity and it hangs out. So it's going to sit on that receptor for a long time, block other things that come in. And then we also get antagonism at kappa, which given time, I will not nerd out on, but we get some mood benefit from that. Kappa antagonism is being looked at for treatment-resistant depression. So I wouldn't say this is why we use it, but it's certainly not a bad thing to have in our pocket. We do want to consider state and federal regulations. We do have to think about when we initiate to avoid precipitated withdrawal. So we want a patient who's either in moderate withdrawal or with whom we do microdose inductions. We do also want to continue this one for patients without a specific contraindication during inpatient hospitalization. And we have way fewer drug-drug interactions than we do with methadone. Largely theoretical, we're looking at CYP3A4 inhibitors and inducers, concomitant CNS depressants. Aside from the concomitant CNS depressants, the one that we hear most is a really rarely used HIV drug. So I would not even say that's clinically something to be concerned about. So again, this is kind of a picture of that effect for those of us who need to draw things out. Naltrexone is our third medication. So this is a full opioid antagonist. It is going to block anything on the opioid receptor. This is an IM injection every 28 days for OUD. It is not recommended to use oral naltrexone for patients who have OUD. Part of the reason that this is not found to be equivalent for mortality reduction as the agonists is because it's just almost impossible to get patients on this sometimes. They do have to be fully withdrawn from opioids. And so fully withdrawn sometimes means like up to 14 to 16 days if we're dealing with some functional clearance issues. That is a long time to be in opioid withdrawal without returning to use. Then you have to have a painful shot that sometimes wears off after 3 months. So we have to watch it and see if we need to adjust our dosing interval. And that really shoots your tolerance. So it's painful, it's not managing your cravings, and then you're going to want to return to use. So what I generally tell my patients is that on a population health basis, I do recommend an agonist. We have better data that indicate that it's going to keep you safer. I cannot promise that the agonists are the best choice for you or your nephew or your neighbor because you're not a population. But I do recommend that we at least start with an agonist because I do worry about an increased risk for mortality if you discontinue naltrexone. Limited drug-drug interactions, which are great, aside from the big one, which is opioids. This is an awesome med for alcohol use disorder. If your team is underusing this, you really this makes huge improvements in a patient's quantity of alcohol used very quickly. For withdrawal management, obviously, traditionally, we had like the alpha agonists, we had dicyclamine, we had ondansetron, like this whole bucket of symptom treatment. Unless you're putting a patient on Vivitrol as the long-term maintenance management, it's now recommended that you go with buprenorphine or methadone to manage withdrawal symptoms. It's more effective for reducing those symptoms of withdrawal, more effective for retaining patients in treatment and supporting completion of their withdrawal. Maintenance management, withdrawal is not recommended alone. One of the things we've discussed here is creating an opt-out rather than an opt-in. So would you like to start a medication for this? Becomes the standard of care for this is to start one of these medications. I'd like to talk to you about that in the same way that we do every other clinical disorder, right? So most of our patients who are diagnosed with cancer do not have a conversation that says, do you want this kind of medication? This is what we do to treat this. Let's talk about how to start that. And so creating that expectation for our patients, knowing that it's that much of a benefit for their overall health might be a really easy way to flip that switch and make sure that you're meeting the standard of care more often. Special patient populations, we do have to think about patients with pain, pregnant patients, adolescents, patients with co-occurring disorders. I have a lot of notes for that on the notes section of the slides. I'm going to go ahead and skip over it for time. Regulatory updates. So telehealth was permissible and is still permissible through DEA and SAMHSA waivers. Because of the public health crisis, there is a strong push to move those along and keep those permanent. Again, access, no barriers. We need these patients started. Nationally, the X waiver certification has changed a bit. Providers can now treat up to 30 patients without that long 8 to 24 hour education requirement. And so that's a great way if you've got a provider who says, I've got 3 patients in my practice who use heroin, have them go ahead and get their X waiver for those 3 patients. It's much less of a time concern now. And then just make sure that you have systems in place that can help support them if they decide to start that practice. 201KR 9270 is the physician side of the buprenorphine regulations. There's a similar one for nursing. I would just make sure that your teams and whoever your champion keep track of those because they change pretty frequently. And you want to make sure that you're operating within regulations, but up to the regulations so that we can expand this in a way that's supported by data and that really does make quick impacts. So again, we are going to try to figure out where we're meeting this need, who's X-waivered, who's not, what are the barriers? Do I have a champion at each of our outpatient facilities? Which services aren't involved that maybe should be? I will put a plug here for pharmacy, of course. What's the patient care experience look like? Have somebody do it, right? If I'm a mom and I'm worried about my teenager, do I know where to go in your system to get help? And what does my experience look like when I go through? He's doing great. Obviously, you're a brilliant hospital who's done a good job. He's trying to get into methadone or Suboxone. What can you start today to start him on treatment? The one thing that you can't start is Naltrexone if he's testing positive. So just keep that in mind. Make sure your teams know what opportunities we have for a quick engagement and to help them out a little bit more. So now it's your turn. You're going to go. For KSHP, I had another half an hour where I had them start to work on these plans and think about it. And I do think, obviously it's a public health concern, so it's something we have to do. We have a moral obligation to do it. We have a lot of energy for it. we have no energy for anything right now. I recognize that. This is not the time for me to be saying you need to overhaul your systems because your providers are exhausted. But that's why I think it's important that we bring in things slowly, right? So let's expand PrEP. Let's have a PGY1 pharmacy resident take on a project to update immunization records and make recommendations for anybody in your system who has had an overdose in the last 2 years. And just see where you can start to make those slow impacts to normalize this as a part of our treatment and a part of our patient populations, and then start to move in those bigger directions. I know that people are tired. I know that resources are constrained. But COVID's not our only public health crisis right now, and we need to make sure that we're addressing this one too as best we possibly can. I ask my kids sometimes for ideas on how to finish up lectures, and this one on the left here was Sam. He's 11. Oh no, sorry, the one on the right was Sam. He found that for me and sent it to me. Work hard and be nice to people. And I think that's honestly it, right? Like, we need to be more compassionate. We need to employ the evidence that's coming in. It's coming in like a fire hose. And so you need a champion at your site who's going to track this and help you guys implement evidence-based interventions. But that's going to lead to decreased mortality. It's going to increase your health, and it's going to make your whole system perform a lot better, and take away some of those things that are probably negatively impacting some of your metrics and some of your rates and some of your care right now. So we have almost no time for questions. I apologize, but I am happy to take them as long as we can.
Thank you so much, Jessica. This is Emily Henderson again for today's presentation. While you are thinking about questions, either unmute yourself and ask Jessica directly, or feel free to type in the chat box and she'll address them that way. While we're doing that, however, Tammy will put in the chat box the CE approval for today's event. Kentucky SOS once again is delighted to provide free continuing education for medicine, pharmacy, and nursing today. Also, House Bill 1 CE for providers. The ID will be listed. If by chance, I know we have several on the phone today, I will email out to all today's live participants the CE instructions. This does need to, you do need to go to the portal and do the evaluation before September 19th at 11:59 p.m. At that time, the portal will close and you will not be able to get CE, receive CE. This presentation and the recording will be posted on the Kentucky SOS website. If for future reference, I will also share it with all the project leads in your facilities. So without further ado, there is the CE for pharmacy, medicine, and nursing, and then Tammy will put up the House Bill 1 CE ID for providers. Any questions for Jessica today? Jessica, are you comfortable with me sharing your email should someone think later of a question and would like to contact you?
Absolutely. Yeah, I'll go ahead and put my VA email here in the box. There you go. And happy to talk with anyone, obviously, right? It's no secret that I love what I do. And so yes, happy to answer questions at any time.
Great. Thank you so much. And I am putting my email in the chat box also. If anybody has questions, you can always email me, Emily Henderson. Well, because time is almost out, thank you so much, Jessica, for sharing your time and expertise and the experience that you have in treating these patients, not only veterans, but others across the state. So thank you so much. And again, thank everyone for attending today's Kentucky SOS webinar. Feel free to contact me anytime and have a great day.
Thanks, everyone.
Thank you. Bye-bye.